Okay, are we ready?
That's great.
Let's talk about World Health Organization guidelines, World Health Organization and UNICEF guidelines for child health in developing countries. We're talking mostly in this context about kids from 0 to 59 months, approximately 1 to 5, 0 to 5 years of age. The reason being is you can do a lot with this age group as far as really making a difference from a missional standpoint, especially when it comes to the community health stuff. But a lot of us who go on to the mission field really don't understand what guidelines and standards already exist out there, and how do we tap into those to really fully utilize them. The challenge with some of this stuff is that when we start looking at World Health Organization guidelines and rules, it can become pretty confusing. And if you've ever been to the World Health Organization website, it's a web of its own, and finding anything is really, really challenging. We've done what we could to pull out some key stuff, and Arnie's been great at, Dr. Gorski's been wonderful at really pulling together a lot of those resources, so you'll find them on both the best practices in healthcare Global Health Missions website, and I pulled some of the core clinical practice stuff together on our clinical resources page. So if you go to our website, you'll find some of this stuff and a little extrapolated and pulled together, so you don't have to search really hard for it. When we talk about child health, just what are the causes of child deaths? This is a pretty good breakdown. You may have seen this. Before, but a good portion of them are neonatal deaths, which is why I thought it would be good to bring Judy in this morning to talk about what can we do to support neonates in the context of, because a lot of these kids really can make it if they have just minimal levels of support. Respiratory illness is another big one. Obviously, immunization, immunization preventable diseases are another big area. But what's the kind of overlying guidelines that we use for child health in developing countries? Does anybody know the name of it? Integrated Management of Childhood Illness, IMCI. Now this is an integrated case management system that was designed to take care of, really to identify critically ill children, potentially critically ill children, and really create some basic guidelines for intervention. It is not a cure-all. It is very remedial for physicians. But what it does do is provides a template that the community health worker who knows nothing about really medicine as a whole can take these basic guidelines and save kids. Identify kids to do basic interventions and get them transferred to the community, into a hospital. They can identify which ones need referral, which ones don't. And it also helps us, it gives us a strategy for what do moms need to hear in the exam room. When we're taking care of those kids, what are those specific things that we need to be doing clinical education on for mom? So now, Laura, would you do me a favor? In the back, there's an IMCI book. Would you just pass that around? There's a chart booklet. Now you can download this chart booklet on our website. You can find it, just type in IMCI chart booklet. But I put them all under the child health resources on our website. So what does this look like? It's a color-coded triage system where all kids are used from 0 to 5 infants are one set of paperwork, and kids from, I guess it's 12 months up to 5 years use another set of paperwork. So there's a little different, or maybe 6 months to 5 years, use a different set of paperwork. Now this is not rocket science for most physicians, but it is a great tool to leave behind. It helps, remember when I talked earlier about the idea of best practices? One of the things that we want to do is facilitate health system development. What you don't realize is that most healthcare practitioners in the developing world are taught these standards. they're taught how to do this. And we come in and we don't pay any attention to this at all. And they look up to us a lot of times. And we don't want to destroy what's really working. Because over the last 15 years, we've seen the number of child deaths in this age group up to 5 years drop from 10 million to 6 million. And I would say it's largely because of this integrated strategy. So if we can get on board with this, at least being supportive of it and understanding it, it gives you basic clinical dosages for the stuff that I'm going to talk about. It's a quick reference guideline. And when you want to do things that we don't usually do here in the States, it's a really good platform. So I'm just putting this up there so you can kind of see an example of how they teach this from the basic health worker level all the way up to the physician level in developing countries. Very effective system. So, but when we're talking about the overall guidelines, talking about really 4 different areas. Patient safety, that's got to be a consideration. Health education and counseling, that's directly stated. Prevention is again directly stated. How do we do disease prevention, assessment, and treatment interventions? So these are kind of the 4 areas that is the overview of what we're looking at. When we talk about patient safety, one of the big things that pops out to me and I mentioned it earlier in my talk, but it's so important, I thought it was worth including in this one as well, which is this idea of pharmacovigilance. That how do we teach moms to utilize their medication? How do we instruct them, and how are we sure that they really fully understand what that medicine is for and how to give it to their kids when they take it home? So the standard is this: mothers of children prescribed home medication must, for each child, verbalize the medication instructions, demonstrate measuring the dose of the medication, and administer the first dose of medication under the supervision of a licensed practitioner or community health worker. That's something that we take for granted here, but it's something that we rarely do, especially in short-term mission work. So it's something that we really need to think about really strongly. We attempt to limit the number of prescriptions. I've seen families come out with literally handfuls of prescriptions. And for so many different kids, they're just not going to lose track. You're going to have a Maria story if you're not careful. And that's what we try to avoid in all of this. Each child treated should have medication dosages obviously labeled with each child's name. And sometimes color coding if moms don't read. I've seen bands with one child to the color of medication. And there's all kinds of creative ways. But the main thing is that you're sure when that mom leaves your clinic that she understands how to give that medicine. Health education, at the community level is really important. And we should be doing it in the exam rooms. And these guys are talking about that next door, but I'm going to touch on it because this is a big portion of, if you get through into the book, you'll see even there's suggested areas of counseling. And we're going to talk about each one of those briefly. But it's really, really important when we talk about these things. Care-seeking behaviors of parents, that's huge. Moms need to receive counseling on that. When, how, and if to receive, to look for further care. Nutrition, both mother and child. Home-based management of diarrhea and dehydration, and malaria prevention. All of these areas are things that we can touch on in the exam rooms. And if you stop by Dr. Gorski's booth out there, he's with the Global Shade booth. He has all of the WHO suggested teaching areas, all divided up with illustrations and all of the teaching on one side, so you can show the illustration on one side and the lesson is on the back. And they're specifically created for exam rooms for physicians to use, not just for community health workers. They'll work for anybody, but they were really designed for pulling the WHO guidelines for clinical education, or community health education. So, why do we talk about care-seeking behaviors? Because poor or delayed care-seeking behaviors are responsible for about 70% or have some interaction with 70% of the under 5 child deaths worldwide. And that's a huge number. So the objective is, in IMCI, one of the keys is that before leaving the clinic, caretaker or moms will know at least 2 danger signs for seeking care immediately. In other words, when is my baby in trouble and when do I need to come into the clinic for care? What is a danger sign? IMCI danger signs are real simple. They're very remedial for healthcare practitioners. But they need to be taught to our young moms who are presenting with sick kids. If a child is unable to drink or breastfeed, so the child vomits everything. The child has convulsions with this illness, or the child is lethargic or unconscious. We go through it's actually 11-day case management program that we teach to healthcare professionals in the developing world, nursing students, physicians. I taught a little segment of this last time I was in the Congo. It is just really invaluable information, and it's just reiterating. Even as healthcare professionals here, we get, we're inundated with information, and it's just good to remind ourselves of the things that we're supposed to do. And these are real basics, but when it comes to practicing in these clinics, it's so vitally important. And it can save so many kids' lives if we do these simple steps. Malnutrition underlies 53% of child deaths globally. So children under 6 months of age should be exclusively breastfed. The studies indicate that better feeding practices could save up to 800,000 lives per year globally. That's a huge number. And what are we doing there? Are we doing anything really technical or challenging? No, we're teaching moms how to breastfeed their kids. Now, there are certain social circumstances where that's not always possible. It doesn't always work as easy as, okay, some moms want nothing more than to breastfeed their children, but their economic circumstances doesn't allow it. They're working in the field down the road, leaving their baby or infant in the care of their 6-year-old. Those situations exist all over the world. So where do we come into that? Helping moms develop strategies, community-based strategies. I've seen community nursing moms. I've seen a lot of that kind of, give them the opportunity. They'll come up with the strategies. But this is such an important thing. And you'll see it listed, specifically called out in the WHO IMCI guidelines as a requirement to teach young moms to breastfeed and how important it really is. Obviously, the rationale for breastfeeding, they say it can reduce diarrhea mortality by 24 to 27%, morbidity by 8 to 20%, and infants aged 0 to 5 months, it can avert 3% of the pneumonia deaths. So it's not just diarrheal deaths that we're talking about here. This is huge, and it's a very simple intervention that any even short-term medical person can do. So what about breastfeeding and HIV/AIDS with HIV/AIDS infected moms? Well, the standards are really kind of vague, but they basically put it this way. The most appropriate infant feeding options for HIV-infected mother depends on individual circumstances, where she resides, what her community level circumstances is, the availability of clean water, availability of counseling services and medications. All these things are taken into consideration when making that decision. As a general rule, when antiretroviral drugs are not immediately available in most of the developing countries, breastfeeding may still provide infants born to HIV-infected mothers with the greatest chance of HIV-free survival, and that's the WHO position. So WHO IMCI recommends 5 prevention and treatment interventions. Immunizations, obviously, no-brainer. We do that all the time. We check kids' immunization cards. Do we do that when you're serving on a short-term medical outreach? Why not? We should. We always should. And oftentimes, if you ask, moms will produce their immunization card. It's amazing what you find when you ask. Anti-helminthic prophylaxis, we want to give kids, you know, it's not the best course, I don't think, but it is the guideline to give kids medicines for scaries or whatever the common intestinal parasites are in your area every 6 months. Vitamin A supplementation, this is a biggie. This is something that we don't do here. We don't need to do it here. And it's way outside the normal range of practice because we're going to give doses that are probably off the charts for most of you. Zinc supplementation and iron supplementation, these are things that we don't do practicing in the developing world for the most part because we don't need to do them. But they're vitally important for the child, you know, for child survival. This little girl in the green here, see, does my little thing work? It's not. Oh, there it is. This is Mackenzie. She's from the Cooper, Dr. Lindsay Cooper is with us in the Congo. This is one of her kids from the Severe Acute Malnutrition Referral Center that she's got there, the Therapeutic Feeding Center. Mackenzie's 8. She's also a very healthy little girl now and is doing quite well. But she came in on the verge of death. So immunization, why immunizations? Immunizations, 20% of the 6 million child deaths, which is a huge percentage, you know, are a result of vaccine-preventable illnesses. So that's something that we need to check, and we need to be active, and we need to be working within the context of systems and structures where we can provide those immunizations when they're needed. So as far as giving kids medicines for parasites, this is kind of a biggie. And, you know, I never really, I've heard varying things on it, and it does seem to be a band-aid sometimes, but ultimately it really is important because these kids get 50 to 70 days, you know, 50 to 70% of the daily required caloric intake if they're lucky most of the time. And now when you take 20 to 30% of that being taken off by parasites, it is, you know, it becomes an imperative for these kids to stay and remain healthy. Vitamin A supplementation. Now, this study came out in, I think it was done in 2008. I've seen some that maybe aren't as confirmatory as this, you know, from some of the literature I've read from Johns Hopkins. But vitamin A supplementation can reduce child mortality by up to 23%. And, you know, we give the first dose anytime after 6 months of age to all children. Thereafter, vitamin A every 6 months to all children. And you'll see that the dosages are a little high if you're working in this program or in these contexts. We give an extra dose of vitamin A, the same dose for the supplementation, as part of the treatment for a child with measles or persistent diarrhea. So, how much do we give? A lot. You know, if a child has had a dose of vitamin A in the past month, you don't need to give vitamin A. But we always record the dose of vitamin A given on the child's chart. You know, age vitamin A dose. 6 months to 12, the 6 months to 12 months, they get 100,000 international units every 6 months. 1 year and older, 200,000 units every 6 months. And these are readily available usually in the pharmacy context via PO, and and you can usually buy them in country. But this is something that you want to think about. And it's really hard to do this kind of work outside, setting up in a church or school. You really need to be in the context of a real clinic that's used to giving these kind of dosages and treating these kids. Management of home diarrhea. Children receive iron and zinc supplementation. And this is kind of probably, this may be something, is this something anybody has heard of in here that has done pediatrics in developing country? Rationale, iron supplementation has also shown to impact child development over the age 2, and zinc supplementation has shown to reduce diarrhea incidence by 18% and pneumonia incidence by 41%. So any child that has diarrhea, we're going to give them zinc supplementation. The dosing on this stuff is readily available in these IMCI guidelines, in the IMCI chart booklet, so it's really easily accessible. You can look on the front cover of it for what you're looking at. You can flip to exactly the page. It tells you where the dose is, and it's really not rocket science. It's they've made it very, very simple. But the idea is all these kids are treated the same from 0 to 5, so that we, this gives them the best chance of survival. I don't know about you guys, but I've been in communities where 1 out of 4, 1 out of 5 kids won't make it to see their 5th birthday. And that to me is heartbreaking. That's why, as a nurse who got involved in medical missions, this is why I started really studying this stuff and trying to learn it, so that I can share it, because I think this is really important information. And just as a side note, I talked this morning about 250,000 probably minimum short-term volunteers going into the developing world every year to do some kind of medical mission work. What if we all got this stuff? What if we really understood what impact, what difference could we make? Because I think it could be huge. But we just need to take the time to step back and look at what are the guidelines, what are the standards, and how do we implement them, even in the context of our 2-week training. Okay, so this is what kind of the IMCI chart booklet will look like when you open it up to the pages that you want. And it gives you pretty much standard dosages. I'm not going to go into zinc dosing, but it basically gives you kind of the breakdown. And this stuff is usually really cheap to purchase. You also see there's only about 21 child health medications that WHO really promotes, especially in this context. And most of them are very effective and you're going to use things that you're not used to using here. You might end up prescribing chloramphenicol. That's not something we use here. It does have some, problems with anemia, but they are so rare, and it's such a cheap, effective antibiotic in the context that we're talking about. And the benefit far outweigh the risk. So you'll see chloramphenicol used a lot. So they're not always going to see what our normal standard is here. And you're seeing now, for just doing general health practice for pediatrics, things look different than we see here. Now I could go into there's a lot of pneumonia stuff too that I think is interesting, and some good research to support that, but I'm not going to talk about that today, because I think what we really need to look at is the stuff that you guys don't know how to do. If you're a physician, you know how to treat pneumonia in a kid. That's not going to be rocket science for you. What we do need to see is how to do things that you haven't done before, like this stuff. Who treats their kids with zinc here? Who treats their kids with high-dose vitamin A here? But it's kind of the basic standard for practicing in developing countries. When we started the ministry one of the things that we realized that there really needed to be a long-term organization that specialized in not only supporting and caring for healthcare professionals long-term, but one that understood that this is different than sending a church, sending somebody to start a church or teaching a Bible college. Because we got all this clinical stuff too that we have to figure out how to do and how to work in the context of the developing world, and with kids especially. So I'm going to let you look up the dosages all on your own, because you guys are grown-up medical professionals and you can easily download them. But it's really a great resource. If you pull this, if you print it out though, I suggest you can have an electronic version, but I suggest you print one and take it with you, because the paperwork is in the back, actually the charting work, and it really helps if you follow the charting with it. And then you flip it over and you can write your whole clinical assessment on the back of that if you're going to use these guidelines. And I really strongly suggest using them. Because to me, they're like ACLS for, they're like our version of, how do we save kids? They're PALs at the community level. So they're worth the time and the effort to follow. Here's the vitamin A supplementation and the dosing. I said it's all broken down. So all you need to do is open it up and then see what's available in the clinic.
So
Here's an
continue the vitamin A? 12, 15?
5.
Just at 5?
Yeah, 0 to 5 is the high priority time frame every 6 months. This is probably a new one for some of you because, if you look at talc, teaching aids at low cost. Oh, it's not teaching aids at low cost anymore. Do you remember what it is? If you go to talc.org, they actually just recently changed their name. They're out of the UK, and they have even a finger stick hematocrit that's really cheap that you can take with you. But when you don't have that, how do we assess? And obviously, as clinicians, we're taught to look at a few different things. But one of the things that WHO recommends is this idea of palmar power as a real good clinical indicator for levels of anemia. And these kids, if they're malnourished, they're going to be anemic. And there's a lot of issues with that for clinical practice that I think I'll touch on some of them. I'm not a physician, so I'm not going to get too into inpatient management of these kids. But I do want to make sure that you're able to access the resources that you need to be effective with these kids. So we talked about anti-malarial may. This one, you're going to have to refer to local, regional guidelines on this because it's different in every country. And these guidelines were really created to be regionally specific. And each individual Ministry of Health has changed them somewhat to be more focused on where they are working. So it may be very different from Central America versus Liberia. So you're going to kind of look at what the context is here, or whether this one would fit. Iron supplementation for these kids that have significant palmar power, or if you can get a hemoglobin strip, to confirm what your suspicion is. This is not going to be a bad thing. Mebendazole or some kind of medicine for parasites every 6 months ideally. Advising mother when to return for care-seeking behaviors. This is a biggie, and you see so much. Malaria in some of the places that we work. And these kids, they come in with some level of malnutrition. And the idea about one of the things that this idea of integrated management of childhood illness. Very rarely do you see a kid that you have to admit to the hospital that doesn't have some kind of multiple problem. They have malaria, malnutrition, and some kind of co-infection. They have malaria, anemia, malnutrition. They have malnutrition, respiratory issues, and measles. So there are always multiple things causing these kids to be admitted. So this is why this systematic approach was developed. It's not that they don't trust clinicians to kind of figure all this out on their own. It's just kind of how do we systemically evaluate this child and make sure we catch all of this stuff. And if you guys have questions, I'm kind of this has turned into a lecture, and I didn't want it to be that. So please speak up and chime in. I'm happy to answer. One of the things that I think is near and dear to my heart is this idea of malnutrition in pediatrics and how do we catch it? Because you know what, when I first stepped into the developing world, I didn't really know how to manage malnutrition. Thank you, Laura. This idea of a mid-upper arm circumference band is really important. This works for kids from about 6 months to 5 years of age. And we can get a really good, quick assessment for their level of malnutrition. In community settings, trained community workers and community members should measure mid-upper arm circumference of infants and children who are 6 months to 59 months of age. While the primary healthcare facilities and hospitals will often, they'll get more in depth and weigh, height to weight, and they look at the whole kid. Ultimately, though, what we found is that mid-upper arm circumference predicts mortality better than any other measure. So this little armband can help us identify malnutrition, and is really a better indicator than some of the other anthropometric models that we use. It is roughly equivalent to using the weight for height for age. So I think that's something that we need to think, and it's much easier and quicker. Yes?
That one little baby you showed that had such bad swelling, that's what you work for early on.
Yeah, that was a quash baby from...
So, I think you could be a little confused if they've got edema because they may not look that thin. I don't think they're that malnourished.
Yeah, that's a good point, and we're going to talk about that in a minute. But ultimately, that's peripheral swelling usually. So you won't see it pulling in the upper arms, you see it pulling in the lower arms and the hands, and in the legs, and in the face. But upper arms are usually okay to measure, and it'll still be an accurate assessment.
So this will be something for short-term trips that they can use instead of trying to weigh and measure kids, right?
Awesome idea.
Yes.
Because usually in those settings, it's almost impossible to get an accurate measurement.
And this is where short-term can help just by doing all the assessments and letting the local people then do their appropriate treatment. But going in and helping with the assessments is a great thing for a short-term trip.
I'm saying, but I'm so frustrated because how people that lead trips to our country, how can they know this? Because usually it's not known.
So now we're all the ambassadors, right?
At least that's the plan. So, this idea of malnutrition is a little, I wanted to touch on this a little bit. Both the assessment, or in the back, there's some, the WHO UNICEF measurement assessment guidelines. And, would you mind you can bring probably all that stuff up, because I think the rest of it is going to go in this session. I wanted to give you the assessment guidelines for this. You're all healthcare professionals. Yeah, I think we dumped one on every table. That should be probably sufficient for now. You can at least look at those, and you can download this. You'll find them on our website, or link to the WHO place where you can pull this down but I think you'll find this a very helpful tool in the assessment of these kids for their nutritional status.
Oh, sorry.
Yes?
Do you have any sort of essential things that a short trip should be doing, like this, or carrying these guidelines, or what else they should be practicing or planning to do instead of?
I do.
Okay.
I have I have a single string violin, and that's that they should be doing it with people who know how to do this stuff. Because if you don't, you're not going to ever, it's tough to learn this stuff if you're only doing it 2 weeks a year.
Yeah.
And if you're not working with somebody who knows how to do this stuff, you're going to miss it. That's why I say work with, when there's hundreds of mission hospitals out there for fighting for survival, and you've got so many long-term medical missions out there trying to keep their head above water. Figuring out how to serve and support them with our short-term missions is, to me, the best thing we can do. But if you're not going to do that, find some good, competent local providers that you can work with, that you can serve and support what they're doing, and that, I think, will give you some real answers in this regard, and and help you be really productive. I'm going to get, the second one she's passing out is the fee study. I'm going to get to that at the end. And we're going to get to some inpatient management here of severe acute malnutrition here in a minute. But still on the assessment end, these are all pictures that I took in the Congo at Dr. Cooper's malnutrition program. There we see about 230 kids this last year, I think. Most of them come in, many of them come in unable to stand, walk, or eat. She does miraculous work with these kids. She loses less than 10% of them. And it's the only, this program is the only inpatient referral center in Eastern Congo, in this region, Eastern Congo. Even Doctors Without Borders refers to it. They do an amazing job of getting these kids back. But severe acute malnutrition in infants who are 0 to 5 months, age is defined, weight or length is less than -3 z-score or standard deviations from the mean. It is in that blue package that you see there is I think pretty helpful. This is kind of the basic. How do we figure out z-scores? Z-scores are just your standard deviations from the mean. -2, -3, you're getting sick kids. So you really need to, pay attention to those. What is marasmus versus kwashiorkors? You brought up the idea of kwashiorkors. This is marasmus. Definition of severe chronic energy deprivation to maintain, deprivation to maintain weight. The extreme form, you see this cachexia, you see muscle wasting, you see these kids just essentially waste away. You see a mid-upper arm circumference of less than 11.5 centimeters in severe wasting, or standard deviation, or z-score of -2 or -3. Very classic. More infants you'll see this way, or when you see older kids, you see some of the kids come in with CP and some other issues that end up being like this, but you see a lot of infants this way. Now this is a classic quash baby. Chronic energy deprivation due to lack of protein, edema, dermatitis, hypoalbuminemia, usually standard deviation of -3. These kids can get very sick, but they don't, to the untrained eye, to somebody who's not a medical professional, you're not going to catch all of this. This is like +3 pitting edema here. And even in the forehead. In fact, when we do assessments for malnutrition, we'll check pitting on the legs, we'll check pitting on their forehead. And you can tell this child, any child with pitting edema, typically needs to be admitted. This is basically an admission criteria right here. So there are community-based nutrition programs that take these kids if they're up and about, but for the most part, as a rule, if you see this kind of edema, you're going to need to admit this kid. But how do we deal with stuff at the community level if you don't have access to admission, and sometimes you don't? This is a recipe for what we call Nirimamba. It was come up with. It's basically how do you make pumpkin nut? Pumpkin nut is ready-to-eat therapeutic food that we use for kids who are severely malnourished but maybe don't meet admission criteria and are still eating. There's two big admission criteria that we look at. Is the kid still eating? And two, do they have edema? Or are they, really cachexic or anemic? You kind of take the whole clinical picture, but ultimately that edema and whether they're eating or not are big indicators whether they need to be admitted. If they're still eating, sometimes they'll put them on a plumping nut regimen. There's another thing called Moringa oleifera. Has anybody heard of Moringa in here? Okay. Moringa is a community-based project It's usually trees. We grow moringa trees. Moringa, the leaves are extremely high protein. They contain every essential amino acid known to man. They are not completely odorless and tasteless, but for the most part. So they can be dried, ground up, and put on rice, any kind of food that the child is eating. They can be put in milk, and they are really. I've seen miraculous stuff happen by putting moringa in kids' food. So some of the more successful projects, if you look up Moringa World Church Service, you'll see a great program that they started out of a clinic in Senegal, West Africa, that really did some amazing things to almost reverse malnutrition in certain communities. So pumping nut's a great stopgap, but it's not the long-term answer.
So this is also an interesting looking to the community for resources story. At the hospital I was working at in Nigeria, the government hospital supplied the ready-to-use food, and they were out of it. And my nurses all were like, well, we know how to make this other thing, which was basically this recipe, but using local ingredients. So, if I hadn't been like, hey, well, what do you guys usually do? They would never have volunteered the information that they already had the answer.
Yeah, and it is that is a great story, because it's something that's often overlooked. I think sometimes too frequently think we have the answers, and oftentimes if you ask a medical professional in a developing country about IMCI, they may not have been trained with all the toys and the high resources that we have, but oftentimes they can probably give you a pretty good rundown on integrated management of childhood illness. I want to touch basically real quick on, this is another one of the children from Lindsay's program in the Congo, and what I want to remind you is that these kids can be turned around. But when you discharge them, they're going to need community support. A good malnutrition program or a good child nutrition program isn't going to be just inpatient. You're going to have an outpatient component too. So these kids go with her. They'll come into the program. They'll be admitted for 4 to 6 weeks oftentimes. They'll be then transitioned to the outpatient clinic portion or to the outpatient program, where they have housing near the hospital where they stay at. Moms learn gardening. They learn basic, they get great counseling. They get great community support too, because the moms have learned that they have a community, that they can support each other, they can learn from each other, they can grow from each other, and that is so valuable in walking moms through this process. Because can you imagine the guilt that mom carries letting her child get like this? But she didn't want to let her child get like this. And I think sometimes we walk in the room and we go, oh my gosh, how did this happen? And moms are going to retract, and you're not going to be able to be the minister in that situation that you need to be. Because you have to understand the social context of someone's family that lets this happen is pretty horrible. And we have to be able to walk alongside her in that time and be able to help plug her into resources and guide her and love on her and show her that there's a bigger answer here, and that it's not always more physical. It's how do you deal with the underlying social context of where they're at, and how do we introduce them to Jesus or help them, and disciple. A lot of young moms in these communities are Christian, so they're carrying this tremendous guilt, and I think sometimes they walk into the hospital setting and they get kind of beat up from healthcare workers who say, you did a terrible job here, and that's the way they made you feel. And we've got to, one of the biggest things we can do is reinforce that it's okay. We're here, we're here because we want to help, and we need to figure out what we need to do to help. And usually it's bigger context than just providing food. So when we talk, WHO has a 10-step process for managing kids with severe acute malnutrition that are admitted to the hospital. These go through basically a few different phases. First is this area of stabilization, here, the first 1 to 2 days, we're dealing with hypoglycemia, hypothermia, dehydration. All of these things are major management issues. We also are dealing with, oftentimes from the get-go, we're dealing with infections. And this is a biggie that we have to deal with, remember, because these kids often don't present with just one problem. They present with multiple problems. A kid that's mildly to, or I want to say moderately malnourished, who ends up having a real bad respiratory infection, or who even has a strep pharyngitis, isn't going to eat. Their metabolic rate increases. What happens? We get them into this cycle where their metabolic rate increases, they're using more energy, they're burning many, many more calories, and they can destabilize pretty quickly, even though they weren't severely malnourished to begin with. We get these kids, they have high output cardiac failure oftentimes because they're severely anemic, they have severe peripheral edema, and they look like a cardiac patient. Their vascular system is just seeping albumin and pulling, allowing fluid to seep peripherally, but they also deal with this cardiac issue from the anemia and from the decreased intravascular volume. So you're dealing with multiple, very complex patient here. So each one of these phases, the first couple of days, we're dealing with these major issues. The hypoglycemia, the hypothermia, and the dehydration. You're going to manage these. You're also going to deal with electrolytes the entire process. And this is complicated sometimes because you don't often have the ability to get them. It really depends on where you work, and sometimes you have good clinical values that you can get laboratory values, and sometimes you don't. Micronutrient supplementation, we talked about vitamin A supplementation, zinc supplementation, iron supplementation. All of those are going to be coming into play at some point. The continuous feeding, we're going to use tube feeding up to a point where usually around a week, then these kids will transition. Sometimes they're going to transition first they're going to transition up to a different level. That's from Angola, that's Dan Cummings from the hospital I showed this morning. Hypothermia, this is a biggie. These kids do get cold. They get hypoglycemic. You're going to be managing this for the first few days. This one is one that we're going to concentrate on a little bit, because this dehydration thing is a big deal. Because how do we treat that here? What are we going to do? We have a kid that's dehydrated, it's in an ER, we're going to stick a line in him and we're going to give him a 20 milligram per kilogram bolus of IV fluid, right? But then we're going to repeat that until he starts looking better. Pretty normal stuff, right? But there's a summary of a study that I put there in front of you. That's the fee study that was done a few years ago in Africa. And I'm going to give you the last few minutes of us are going to watch a video on that study and some of the results of it. But essentially, management of rehydration therapy in these kids needs to be via nasogastric tube and a much slower rate. And we're not going to blow them out with IV fluid. It's not that they don't need an IV, but you can't give these kids big IV boluses if they're this sick. What was kind of surprising to everybody was that these kids have a much higher mortality, and we actually induce mortality by giving them large fluid boluses. So we have to be cautious about that in managing these children. So we usually, you'll see here, this little guy's got an AG tube. So when they come in dehydrated, this little guy's got malaria, he's pretty much unresponsive. They'll put the NG tube down and we'll do the oral rehydration before they turn to IV fluid therapy. If you can get electrolytes, you really want to know where you are there, because that's huge with these kids. Being able to do at least basic chemistry is really important. If there's any way at all. Uncomplicated infection, cotrimoxazole or amoxicillin are acceptable. You're going to go into Gent and or chloramphenicol, ceftriaxone, or some of the more some other medications if you're going going to get if you're managing these kids that are this complicated and this sick. Irons, we talked about iron supplementation. B vitamins is another one. Vitamin D. There's a protocol for supplementation on these kids that you can easily pull down. This whole set is available through WHO. Anybody can pull this information and have it with you on your phone when you need it. You're gonna, it's when you get up to step 7, you're going to increase their caloric intake from F75 formula to F100, and then eventually you're going to pull their tube and get them into eating community foods. So that's where you want to get these kids to. Stimulation of the environment, you want to get them up, moving around, you want to get them outside. But then preparation for discharge, and that really has to be a good, strong support system. You've got to be able to put them somewhere where you're going to have a readmission. So you've got to figure out how to manage these kids after the fact. What's the community development program that's going to teach moms how to care for their kids, but also how to produce, how to manage the food production in their lives for their family, because that's going to be an important piece of it. And there's other aspects of that. This is just kind of the formula production the formulas that we use, but there's actually, I showed you a picture of Nurimamba, which is the community-based. Basically, it's peanut butter and high vitamin content. There's ways to mix this. They mix a protein-rich porridge for the kids. Did I have it? Yeah, these kids. This is part of from that same program, the Congo Lindsay's program. But these kids they get a protein-rich porridge. They force feed them, essentially. They get moms to start feeding them as soon as they can. And it's an ongoing process to get them to eat again, because they literally stopped eating. So it's a whole process that has to be gone through. But you can't just discharge them. They have to go out to the community in a place where where they're going to be able to have adequate support. I think this is, it's a few-minute video. It's worth watching, because if you haven't been exposed to this study, it's important. And it's the one saying, well, WHO throws big umbrellas over stuff and oftentimes don't account for good clinical decision-making, and that's true. So as physicians, you're always going to really look at the clinical picture, and it may not be as black and white as the IMCI or the WHO guidelines. This is one thing that they're pushing WHO to make the change, but WHO is a huge machine and it hasn't. So if you pull the present guidelines, they're still going to say to give the kids 15 ml per kilogram bolus, which is probably not supportive. It's not supported by the literature at this point, so we've kind of moved away from that. So NG rehydration is really the way to go with these kids. And we're expecting that change to be official in WHO pretty soon. Even in PALS, I teach PALS, and we've already begun to incorporate and say, look, there's been studies from abroad that indicate that not all contexts these fluid boluses are appropriate. So I think you'll see it pretty soon in the WHO literature as well. It's a big ship to try to re-steer. I'm going to try to play this in here, and if not, I'm going to pull out and then
5-year-old Achen Loi has just arrived in hospital with suspected malaria or sepsis, a bacterial blood infection. Every year, these illnesses kill more than 2 million children worldwide. There are effective medicines, which Achen is being given, but she's already in shock. She has a weak, rapid pulse with cold legs and arms. Her body is concentrating all the blood to the vital organs in an effort to stave off death. To save her, the doctors need to keep her alive long enough for the medicines to take effect. In wealthy countries, children in shock like a chain would be given a large emergency dose or bolus of fluids in an effort to restore circulation. But there, doctors also have ventilators and other life support machines to keep children alive. Like most African hospitals, ours does not have such equipment. So, as a doctor working in Africa, I need to know if it is safe for me to also give boluses. Or should I give fluids more slowly just to replace what a child should normally drink? Even in wealthy countries, the evidence to answer this vital question is weak. The FEAST trial is the first large randomized trial anywhere in the world to see if it is safe and effective to give boluses of fluids to critically sick children with shock. My hospital in eastern Uganda was one of 6 sites in Uganda, Kenya, and Tanzania where the trial was carried out. The FEAST question is very important here because too many children still die of malaria and sepsis. They arrive in hospital already in shock and die in the first hours. So finding out how to use fluids to keep them alive a little longer could save many lives. We started with intensive training on basic emergency care to allow staff to quickly identify and give priority to very sick children.
1, 2, 3, 4.
These are important skills which require people to work as a team. These simple measures alone improved survival of all children at the hospitals where FEAST was done. Over 2 years, we recruited more than 3,000 children with shock caused by malaria, sepsis, and other illnesses that produce fevers. We did not include children with diarrhea, trauma, or burns who need extra fluids. The children were divided randomly into 3 equally sized groups. 2 groups were immediately given an emergency fluid bolus. One group saline, the other albumin. The third group were given fluids more slowly at the amounts needed to maintain normal levels.
The main outcome that we're interested in, and which we called our endpoint, was to ascertain the number of children who survived within the first 48 hours of admission.
The answer came sooner than expected. The trial was stopped slightly early by the committee overseeing safety.
The results showed that 89.4% of children who received boluses survived the first 48 hours in hospital. However, children who didn't receive boluses but were given fluid more slowly did better. 92.7% of them survived. This difference is significant. It means if we give boluses to all African children with shock, as in the FEAST trial, between 3 and 4 in 100 would be expected to die as a result of the treatment.
Had a bolus. So boluses were not saving lives.
When the trial team was told the results, there was general surprise. The trial found clear evidence that giving boluses was actually harmful.
The results surprised me because I saw a couple of children improving after getting big amounts of fluids. But I was more surprised because the results were against the current recommendations by WHO and against what is the normal practice in the wealthy countries, and this surprised me absolutely.
We are quite sure that the results are accurate. Every piece of data was checked several times.
The study was conducted to a very high standard. It has achieved a level of adherence to the protocol and a level of retention I haven't seen in my 25 years of working in clinical trials. And for all these reasons, I believe that the results coming from FEAST are reliable.
Children around our 6 sites are exposed to a wide range of illnesses. We had large subgroups for malaria, pneumonia, meningitis, anemia, and others. We also looked at different definitions of shock, including the strict WHO one. All the results pointed the same way, and it made no difference the type of fluids, whether saline or albumin.
We've examined the data very carefully and we can find no single subgroup in whom fluid boluses are of any benefit. We're therefore going to recommend to the WHO and other policymakers that fluids given by a drip should only be given slowly and to replace that would normally be drunk by a critically sick child.
It is important this message is not misunderstood.
We're kind of timed out, but I think that gives you enough of this video to help you understand the study a little bit more about it. I would encourage you can download the actual study off of our website if you're interested in reading a little bit more. But it does kind of tell us that maybe, at least in this context, that you know, blowing these kids out with large amounts of fluid is not the best approach, which is contradictory to some of the things. So what I wanted to bring out here today was, you know, that maybe caring for kids in developing countries looks a little different than caring for kids here. And, you know, we don't have all the answers, but I want to just give you the ability to point you to some resources that may be of real help to you in this regard. Does anybody have any questions, you know, that I might be able to help with in the meantime?
So for kids with diarrhea or burns, you would still likely bolus?
Yes. I don't know if she had covered that or not. I may have missed it, but she does talk about that at some point in the video. That obviously, you know, there are certain situations where diarrhea, illness, gastrointestinal illness, burns, those things you're still going to give the same fluid boluses. Yeah.
It's okay, guys. Come on in.
Yeah, come on in.
Please come in.
Okay. I guess that means we're timed out, and we need to move on to the next session. But thanks for your attention, and I hope this was helpful.